Out of Spain's 40,000 cases, we have 5,400 actually affecting healthcare professionals. The same is pretty much true also for Italy and the rest of the world. There are 37 Italian doctors we know to date which have actually died. We know that we have 3 more cases which actually occurred just in the last 3 days, and one of them is actually a very good colleague of ours. He is the head, or used to be the head of the European Society for Cardiovascular Imaging, the vice president there, and he just recently died in Naples. Of course, if we hear these figures, it really gives us shivers, and we know that we as healthcare professionals are at the forefront here and very much, of course, in a risk situation of maybe also being affected. But being affected not only means that we die or get sick or might even have an illness that will have long-lasting effects, but it also means that we cannot give care to the others, and it also means that we are people who can infect others. So these are some of the things we will discuss in the webinar, something that is very much on my mind, and I think in all of you, and I'm very, very happy to have speakers with us from all around the world where we'll discuss this topic, but also the topic of how can we protect ourselves, what can we do to manage the patients correctly, and we will also focus on a very, very important topic, namely on point-of-care ultrasound, which in this situation might be a very good diagnostic tool, and we'll discuss that in more detail in COVID patients. So let me introduce to you, of course, Martin Altersberger. Martin Altersberger is one of the, I would say, young generation doctors. He is someone who's learned ultrasound very, very early on in his career, and he's pushing this technology forward, and I'm very happy to have him with us. Then we have Dr. Jalal, who is from Texas. He will give us his perspective on what the situation in the moment in US and of course also in Texas is. He is someone who's working very, very heavily now also in preparing everything for the number of patients which we hope not, but probably will also come to the US and to Texas. And then we have from France, from Paris, Jean-Jacques Rouby, who is an expert in pulmonic ultrasound and also in intensive care medicine, and he'll give us his perspective. He'll also talk more together, of course, with Bilal on the topic of point-of-care ultrasound. But before we go into these topics, let me just talk a little bit about the current situation and just start by giving you some statistics which I think are very, very impressive and important to know. And I think many of you have seen these statistics. Those are the trajectories of cases in different countries. And if you look at these curves, you will realize that different countries have different rises of cases, which essentially also means that the mortality will be different in different cases just based on the numbers that we see. And if you take a look at this statistic, you will see that China is now flattening off. But you see that we have other countries which have an even steeper rise, and we know the situation in Italy has been devastating, in Iran. Now Spain is very much on the rise, and we have US who just surpassed even China with number of cases. So this is in a way something that is worrisome, and if you pick out some of the countries some of the cities or regions we're looking at, we see that actually Madrid is now almost in par, if not even surpassing Lombardia as the region which has the most cases. And what is also very, very worrisome is the fact that there are some countries which might have an even steeper trajectory. We have to be cautious because the numbers and the data and the statistics is of course very difficult to compare simply based on the fact that the number of people we test varies from country to country. But if you just look at some countries such as Turkey here, or if you look maybe at countries as maybe Poland or some others, they are certainly in a situation that they might come to a very similar situation as those regions that are now so much in the news. So I would like to first discuss a little bit what the experience in the various countries is, and maybe we can have first Jean-Jacques report a little bit about what the situation at the moment in Paris and in France is. We know France is also being heavily hit, and we see rising numbers there as well. Jean-Jacques, can I have your review or your impressions?
We have more than 3,000 that are considered to have SARS-CoV-2 pneumonia, but non-critical. They are staying either home or in the hospital. And we have 1,600 patients admitted in intensive care units. But the situation is not really homogeneous, in France. East and Île-de-France, the region of Paris, are heavily contaminated. South, west, northwest are really in a quiet situation. So the fact that we have two regions that are massively involved with the outbreak raises very specific problem. In these regions, hospitals are either overwhelmed, ICUs, by critically ill patients, or like in Paris right now, just on the limit. So we think that we have in Paris 200 beds that are still empty. And we think that in 1 or 2 days, they will be occupied by patients. So then after, what are we going to do? One solution is to move physicians from other regions of France to Paris and East, like was done in China. Many of our Chinese colleagues went from different provinces to Hubei. In France, it's going to be difficult to do that. So the other option is to move patients to ICUs, patients from Île-de-France or east of France towards ICUs in west and southwest. Yesterday, there was a fast train, a TGV, that was that transported from Mulhouse in the east part of France to Tours, middle west, 25 critically ill patients to the ICU. So we don't know exactly what is going to do, but right now the ICUs are working. We have a sort of war organization in the ICU to have enough doctors, enough healthcare providers, and also to permit the other to rest. This is very important because it is a tough job. So let's say it is under control, and in 2 or 3 days, it's going to be difficult imposing solutions.
So I see that the trajectories that you're seeing would mean that you probably would reach the peak of patients when? When would you think you would reach the maximum of patients?
3 days, 4 days, 5 days, we don't know exactly. Let's say beginning of April. France was constrained 10 days ago. So if compared to Italy at the same period, according to the beginning of the outbreak, we are 1 week in advance. So we hope that the curve you showed coming from Johns Hopkins, France is a little bit under Italy. And so we hope that the confinement en français, is going to reduce the number of critically ill patients to admit.
On a personal front, in your hospital, are you seeing a lot of patients, and can you describe how these patients present? Is it exactly as you would see them from Italy? For example, do you see younger patients? Do you see many patients being admitted to the intensive care?
The mortality rate, once the patient has been intubated, is like in China, around 50%. So it's a terrible situation. Most of the deaths were observed in elderly patients over 80 with severe comorbidities. And let's say that 70% of deaths were related to the decision of the medical team and the family on phone to stop the ICU support. It was the main cause of death. The mean age is 60. It means that we admitted patients from 35 to 87. But we have already relatively young patients in the ICU. We did not observe one death in these young patients, but you know, the mean duration of stay in the ICU for SARS-CoV-2 pneumonia is 2 to 3 weeks. So we have to wait to see what will happen to these young patients.
Of course, this is also a problem with respect to the resources. If patients are very long on the ventilators, you cannot get the ventilators free for new patients, which I also see as a big problem. I would like to come to Dr. Bilal now and maybe have his take on what is going on in Texas at the moment. We know that New York is heavily hit, but what about the situation in Texas?
We're just going to start seeing these numbers uptick. And this is focusing now only on the United States. And obviously there are 4 states that have been hit the worst with the virus. New York, the news has it all over. I know for a fact that there are some hospitals in New York that have a critical shortage of ventilators, but New Jersey is a neighboring state to New York that's been hit fairly significantly, not nearly as bad as New York. Texas on this list is at number 11. Still barely above 1,500 cases, but that number is climbing very quickly. We're short of New York, where I think we're rising fairly fast. And this is from the New York Times that I pulled kind of comparing data for the US and Italy. And you can see how on a linear curve, it doesn't really depict it so well. But when you go to a logarithmic scale, you're seeing the rate of change a lot better. And you can see that that curve in Italy is kind of flattening out. This data is obviously a week old from the New York Times, but we can still see a week ago, the US was still on a steep uprise. And then when you go to the next slide, you'll be able to see that that data point that I talked about, tracking serious critically ill patients in the world. This it's very interesting. So I updated this slide yesterday, and I did make some changes to the presentation this morning because the statistics had changed significantly. Primarily that the U.S. had taken lead on the number of cases worldwide. But this graph was at 15,000 yesterday when I downloaded it. And today when I looked at it, this is up to 20,000. So we have 5,000 new cases that are critically ill. On the right of this graph, you can see this is from Forbes, and they're kind of giving us an estimate of how many ICU beds we have per capita. And despite the United States having one of the highest number of ICU beds in the world, we still also have a fairly high utilization of ICU beds. And we will eventually come to the point where we're going to run out of ICU beds. New York has already gotten to that point. I think there's some naval ships being moved there that have hospitals on them that they can take care of patients on over there. But this is coming. This is going to keep rising, these numbers.
Those are really, really, of course, scary numbers. Numbers are rising very quickly in the US and, of course, also in Texas. And there seems to be more and more patients coming into a critical situation. And you do also expect that you will come into a situation where you do not have enough critical care beds?
I think very interesting question. So this is a website that's kind of tracking the utilization of hospital resources in the United States. And you can see it's very funny that on April 14th, that's my birthday, but on April 14th is the day that we're going to actually run out of critical care beds in the United States. For Texas, that changes to April 14th. Obviously, this is still a projection, but this is data that is being formed by big data and the analysis of large numbers. I would believe this until that curve flattens.
With respect to the whole issue of ventilators, do you expect the US to ramp up with the amount of ventilators? I know there's a lot of efforts now within the industry where certain industries which have never really produced medical equipment are now all of a sudden trying to produce ventilators. Or do you think that this effort will simply come too late?
The first part of that is that even the companies that are ramping up creating ventilators, are they the ventilators that we use every day in an ICU where, you have multiple different modes, hybrid modes and other different modes? Are these going to be just CMV ventilators that are not going to be very useful, in fact, may harm patients? It's very hard to tell until we start using these ventilators that are pushed out very quickly.
I think we'll talk much more about the management of patients, because I see we're getting a lot of questions in that I definitely want to pitch to you. But this is a final question before we move on to maybe Martin and let him give his take on South Korea. You'll hear why he's going to talk about South Korea a little bit later. But my question to you is, did we react too slowly? Should we have been faster in the way we reacted, or would have been unpreventable anyway?
So I think, I'm not sure if that would have absolutely helped. I do think that as far as the United States is concerned, we should have thought about shutting things off a lot sooner than we did. And I think that may have protected us, because we have to realize there's a 5-day incubation period, and then there's 5 days of me carrying the virus around, give or take. So that's a 10-day lag period that you're going to see. So from when a shutdown is implemented, everything you see in the next 10 days is actually what happened before the shutdown went in place. So we still haven't seen what the effects of limiting social distancing and all those kinds of things is going to show us, and we'll find out in the next few days.
Okay, well, thanks a lot. We'll come back to some of these issues a little bit later, but maybe we'll have Martin now. Martin, what is the situation in South Korea?
Why I'm talking about the South Korean situation. So my wife is South Korean, and of course her whole family lives in South Korea, and I hear every day how they are dealing with the COVID-19 situation. So I found quite a nice and interesting article about contact transmission of COVID-19 in Korea and tracing contacts. And what the authors are describing is that we are facing an, for now unknown, or at that time unknown, infectious disease. And for an unknown disease, you have to determine the prevalence to explore the cause. Now we know it's the viral disease, explore transmission, and of course, then prevent transmission. And we do know that individuals become the source of infection, and person-to-person transmission is, of course, suspected. It is very important to identify the patients or the possible patients and appropriately manage the people. We have to classify the contact persons, evaluate the exposure, and also think about the possibility of environmental contamination and disinfection the area. This is the web page of the South Korean government on COVID-19 cases, and it's updated on a regular basis, so more times a day or several times a day. And thankfully, as I'm also not that fluent in Korean, there's an English version of that page. In the middle, we see South Korea, and the red areas, those show the infected cases all over South Korea. Here we have the English version of the page, and it is quite nicely displayed that you see the confirmed cases. And in Korea, today there were 9,332 cases confirmed, deceased 139 patients. And if you look at the tests performed, there were 377,000 tests performed in South Korea since the outbreak started. So there's a lot of testing going on in Korea. Here you see how the Korean government communicates also to the people how they are planning to quarantine and how quarantine worked, and that there's a central disease control headquarters, of course, and the measurements or the measures are directed to local municipals. In Korea, it was from the beginning very important to prevent the inflow and the spread of the infectious disease. So they set up quite strict rules on how to deal with patients or people coming back from other countries. And one of those measures was everyone who enters the airport and enters Korea, they have to install an app. This was a very simple app, and you had to download it, and you had to monitor your symptoms and your health status 14 days. So every day for 14 days, you had to document if you had fever more than 37.5 degrees, or the feeling of having fever, coughing, or dyspnea. And this data is available for the government, and then they were able to deal with patients individually. That is a very nice image. I think it's how early detection of infected patients happened in Korea. They set up specific drive-throughs, so screening centers, and in the second picture you see a car, and how the testing was made. It's just everything happens in the car. So the people or possible infected people with COVID-19 keep the distance. So social distancing was very, very popular or important there. As soon as someone was infected or confirmed with COVID-19, this is an example of Seoul, and in Seoul you saw the personal data was stored, so the nationality, the sex, the year of birth, not the exact date of birth, the route of transmission, and the confirmed date of the test being made, and where the patient is a resident, and also where the patient is isolated. And what's more important or even more interesting is that there's a specific patient's movement path. So the Korean government used GPS data, and they also used the so-called CCTV. So that's kind of like a closed circuit television. It's a security camera system all over Korea. And with all this information, they restored or created all the maps where COVID-19 patients were. So you know when you had contact with those patients. And you see each and every dot had a specific or has a specific kind of information where this person was infected, where this person was. And if you are infected as well, you got a message via an app so that you know that you were or you are possibly contaminated, and then you are invited to checkup. And in the next slide, we see the same example. So every region has a different web page, and it is displayed basically the same. So you always have the personal data with year of birth, the sex, the residency, the route of transmission, the number of people you contacted, the isolation facility, and the confirmed date of when you were infected. And the aims overall in Korea was to create accurate information and especially minimize the fear and the confusion of the inhabitants, and to also still to have a protocol to protect the privacy of the patients as well. So that summarizes basically what was done in Korea.
Well, I can only say this is very, very fascinating to see how they are using digital technology to fight the battle against COVID-19. Of course, the technology definitely is there, and they were just quick enough to utilize it. Especially, they also used a lot of testing. And maybe I'll just pitch the question to you, Balal. What are your thoughts on, should we do more testing? Do we do enough testing?
Testing has two things that it changes your management from, right? One would be that you isolate that patient. If you test them, then they test positive. And the second is you add to statistic. So the numbers that we're accumulating, because there isn't, and we can talk later about treatment options, but there isn't very good treatment available for coronavirus. In fact, for most viral infections, the treatment is supportive care. So testing the appropriate population, I absolutely agree with. If over testing is with an intent to limit the movement of those patients, absolutely that would help. But if testing is only being done to add to a statistic and there's nothing more that's happening after that, I don't necessarily know that would be helpful.
I think that is definitely something that I probably would agree with. And again, coming back to what you mentioned too, the digital technology, this is also being very strongly applied in China. And I can just show you here on my slide. You can see that they use the QR codes. If you go into an entrance, they have the apps. They know, of course, much better where someone has been within the last 14 days. And they can control much better and see who is actually the patient who is arriving. So this is a very, very important part of the prevention program in China. And I believe that this is something that probably could be initiated in many countries, Western countries or Eastern countries that are now strongly affected by COVID as well. This does bring me also to the situation in Austria. And we in Austria, I think we're one of the countries which started earliest with the preventive measures. We were, among the probably 2 or 3 countries who were the first to, have a quarantine and lock down cities and even lock down certain regions. Austria was, of course, in a geographically difficult situation because we're very close to Italy. And we have another situation which makes it quite difficult. We have a lot of tourism. So there's a lot of travel. And the hot area in Austria is actually Tyrol. Tyrol, as you know, obviously is a place where we have a lot of skiing going on. And in this region, where you see the hot map very, very high, this is where we have the shutdowns of specific regions where these people are actually completely locked in their towns. But we do see cases in all of Austria. We see them in Vienna, but not as much, of course, as in Tyrol. We have them in Upper Austria. So there's a pretty continuous spread of the virus throughout Austria. And coming back to the situation that we had in Tyrol, in the Arlberg, which is one of the most famous ski resorts in Austria. The interesting thing was that one of the major problems there was that it spread from actually one place mostly. That was a disco or a bar, which it was in a skiing resort in Ischgl, and from there a barkeeper was spreading the virus, and we can even see traces of that virus all the way up to Iceland, Norway, Sweden. So this is how the virus actually spread to certain regions. I guess this is something that you will probably see in every epidemic, that you have certain traces where the virus is moving based on where a lot of people come together. And in this disco in Tyrol, people are very, very close. It's very famous to go après ski, as we say, after skiing, and that's how they were infected. Luckily, like I said, these areas were shut down completely, and luckily we started the preventive measures very, very early. We do see a lot of cases though, but at least when we look at the news, we have optimism that we might be able to have a trajectory which is not as steep as in other countries. But again, we have to watch out for that. And in reality, we have a really high, I would say, discipline among the population, the people as well.